Can I get a Brady? Can I get a little tacky? What it is, what's up, everybody? We are here and diving into another Robjob Rapid review. We are covering, what are we covering today? Oh yeah, arrhythmic pharmacology. So without further ado, let's dive into the meat and potatoes. Here we go, and boom. All right, here we are. Here's our flow chart for the day. So arrhythmias, this is when there's irregular rhythm in your cardiomyocytes. So you could be going too slow or too fast. And today we'll be talking about the drugs to manipulate that conduction system and try to get things more regular. This is a very interesting category of drugs. A lot of them have ranging side effects, and the use of them is definitely controversial. And it's just definitely important to be careful when using these drugs. So when we look at these, we look at the Von Williams classification of arrhythmic drugs. And this classification goes class 1, class 2, class 3, class 4. And how I kind of set this up with a mnemonic is sodium beats potassium cravings. You know, like everybody loves salty food, a nice pizza, but like a banana's all right. So sodium beats potassium cravings. We're going down 1, 2, 3, 4. Sodium blockers, beta blockers, potassium blockers, calcium blockers. The effect on these, so 1 and 3 are going to affect rhythm. So the sodium and potassium blockers are going to affect rhythm. And then the beta blockers and the calcium channel blockers, those are going to be what you're going to use to affect the actual rate. And then before we kind of dive into the flow chart here with the different drugs, I just want to make sure that everybody kind of has a general grasp of an action potential in a cardiomyocyte. So here's the 4 phases. Phase 0 here is when sodium's flooding into the cardiomyocyte. That's what we call depolarization. Then we have potassium coming out. We have calcium coming in. That's the plateau phase. And then the potassium coming out during repolarization kind of finishes off that action potential. And then we go to our resting membrane potential there. So each of these drugs, whether they're the sodium blockers, the potassium blockers, calcium or potassium, said potassium twice, they will be manipulating the conduction system. So anyways, without further ado, let's dive in. Big picture here, guys. We really want to think about 1 and 3 as affecting rhythm, and we want to think of 2 and 4 as affecting rate. So kind of just to decipher that, what I kind of did here is I looked at all of the ones, 1A, 1B, 1C, and they all have cane. And then 3 is the ones that also affect rhythm. I kind of do the acronym ADS. So cane, ADS. So we're thinking 1, 3, cane, ADS. That's Procainamide, Lidocaine, Flecainide. And then we get to the ADS, which is an acronym for Amiodarone, Dronaderone, Dophetilide, and Sotolol. So those are the ones that are going to affect rhythm. And then we only have one drug that we really need to get down here, or 2 drugs essentially for the beta blockers and calcium channel blockers. And that's Metoprolol, the beta blocker that we've gone over ad nauseum. And then we got Adenosine here. So now that we kind of have that picture, we can dive in. The first one is a drug that keeps coming up. It's Digoxin. In my last video, I called it Digoxin. You know, we're still learning the ways, but the mnemonic here is DiGiorno. No more delivery of sodium, it's DiGiorno. So essentially it inhibits the sodium potassium ATPase channel, and it drives the influx of calcium. So what we'll see here, the cardiac effect of this is we're going to see increased parasympathetic activity, and then we're also going to see delayed conduction. We're going to see an increased effective refractory period. So this part of the action potential will also be extended. Now, when we dive into the class 1A, 1B, 1C, what is class 1 again? Sodium channel blockers. You got it. All of these are going to have a specific, each one is going to have a specific effect on the heart. So the first one, Procainamide, Pro number 1. So Pro 1A, that's kind of the mnemonic I have here. And this is going to do both. So the Pro 1A is both going to extend the action potential duration, and it's also going to extend the effective refractory period. It has like what's known as an intermediate effect. So just thinking that the first one, although it's the top dog and it's affecting both the action potential and the effective refractory period, it does have an intermediate effect, which is a little contradicting. When we get into lidocaine, you know, the dental office, small pinch, we actually see a decrease in that action potential duration in the effective refractory period. And it's fast acting, but it has a weak effect on the AV node. So here, just think like the first one, we're increasing both. The second one, we're decreasing both. So this will be more narrow. And then for the last one, Flecainamide, we're like flailing, like, oh my gosh, flailing, strong effect. There's no effect. So there's no effect on the effective refractory period, but there is a slight decrease in the actual threshold of that membrane potential. So it'll like decrease what's known as Vmax. Again, class 2, metoprolol, we're in the OLOLs, so that cues us in to a beta blocker. We know that these beta blockers are beta-1 antagonists. What does beta-1 do? Yes, you're right, that increases heart rate, so these decrease heart rate, and this will actually increase the action potential. So this is something that we can use for bradycardia. Now we get to our ADS. So just think that about the potassium channel blockers as ADS. The first two here, Amiodarone and Dronaderone, they are both potassium and sodium channel blockers. And the reason why I highlighted the I in Amiodarone is it's important to know that the I Amiodarone has iodine in its structure. So it does have a little bit more of a toxic effect from Dronaderone, but they both mechanistically do the same thing. All of these, since they are blocking that potassium from leaving the cell, it's going to extend that effective refractory period. So that's really important to cue into. When we go down past Amiodarone and Dronaderone, and we get to Dophetilide, one random fact about Dophetilide is when it was discovered, it targets a specific potassium blocker. It's called the ether agogo channel. Wake me up before you go, don't go. So the mnemonic there is do-go-go, Dophetilide, potassium channel blocker. We're thinking ADS class 3. I hope I'm making sense here, guys. So the last one is Sotolol. What do you think when you say ALOL? ALOL, ILOL, OLOL. We got a beta blocker, everybody, but it's also a potassium channel blocker. So this is also going to extend the effective refractory period. It's a class 3 drug that we can use for rhythm or arrhythmias. And it's kind of like it's got a dual purpose. It's got the potassium channel activity and it's also got the beta blocking activity. Look at that. We only got 2 more drugs. So class 4, we got Verapamil, like verap my way to a calcium blockage. What this does is it's cardioselective. So Verapamil is cardioselective. It's going to actually just target the heart here, and it's a calcium channel blocker. So what this will do is it'll decrease that threshold. We won't have as much contraction. So we can use that to modulate the rate if we need to for someone with arrhythmia, or a patient with arrhythmia, I should say. And then the last one is just a class 5 nucleoside, adenosine. Adenosine, the mnemonic that I've been using, it's not even a mnemonic, it's just straight scientific fact, is that adenosine is a sleep molecule. So a fun fact for those who don't know, adenosine is what's known as like the sleep pressure molecule. It circulates throughout our bloodstream. And it's actually one of the main drivers that puts us to sleep at night. So what I'm thinking about when I think of adenosine, when we're administering this intravenously, is we're trying to slow things down. We're trying to increase that parasympathetic activity. So that's what adenosine does. We administer it via IV and we block that AV node conduction. And what's important to know about adenosine is you're not going to use this for AFib, because this targets the AV node, where AFib is, the pathology is mainly associated with the atria of the heart. And this is specifically acting below that at the AV node. So would you look at that? We just ripped through arrhythmia pharmacology, a quick and easy. The big picture here is 1 and 3 rhythm, 2 and 4 rate, 1 and 3 Caine ADS, 2 and 4 beta blocker and adenosine. Say that 3 times fast, 5 times fast, and I think you'll have it ready and down for the test. I hope I have it down for the test. Anyways, thank you folks. Over and out.